psychiatry, pathology, psychiatric emergencies. All right, so these are our scariest psychiatric emergencies. They're mainly going to be due to or secondary to drug usage, okay? Whether that might be the drugs that we give them, treatments that we give them most of the time, or, a drug that they could have taken from the street. But most of the time, it's going to be something that we have given the patient, all right? So they're very, very scary, and some of them present very similarly. So let's start off with serotonin syndrome. All serotonin syndrome is an excess in serotonin. And any drug that increases 5-HT in your system can cause serotonin syndrome. So be mindful of the drugs that patients are taking. If they're taking any drug that increases 5-HT, they are at risk of serotonin syndrome. So take a look at that long list. Whenever you're reading a question, they'll give you this patient's on this, and this. Make sure they're not on multiple medications that increase 5-HT or essentially increase serotonin in the body. So the psychiatric drugs are like MAO inhibitors, SSRIs, SNRIs, TCAs, and then just like a plethora of other ones, right? Non-psychotic drugs could be like tramadol, ondansetron, and we're going to get to those other ones too. But just keep in mind, any drug that increases serotonin levels is going to put you at risk of serotonin syndrome. So how are they going to present? The patient's going to present with increase in activity. They have hyperactivity. So they'll have clonus and hyperreflexia. So the clonus is very key here. The clonus and hyperreflexia are key in differentiating serotonin from other things. So hyperreflexia and clonus are key to serotonin syndrome. Other things you're going to be seeing is autonomic instability. So they're going to have hyperthermia. They're going to be sweating a lot, diaphoresis, they'll have diarrhea. And the last ones, they're going to have altered mental status, okay? Now, the treatment, you have to give them benzodiazepines in supportive care. You could also give something that's higher yield is cryptoheptadine, which is a 5-HT2 receptor antagonist. So cryptoheptadine is going to block that receptor, that serotonin receptor, which will help with the symptoms. Okay, so benzos and cryptoheptadine. I'm pretty sure cryptoheptadine was what I saw a lot more often as a treatment for serotonin syndrome. But remember, the treatment is important. All right, the treatment in the context of the patient. The context of the patient would be what drugs are they taking? So if they're taking serotonin increasing drugs, that should be your first clue. The second clue should be the symptoms, the manifestations, hyperreflexia with clonus. Okay, very key. Next is going to be our neuroleptic malignant syndrome. Okay, so for neuroleptic malignant syndrome, NMS, okay, this is how we describe it. It's going to be caused by antipsychotics. Okay, usually the typical antipsychotics more than the atypical ones. Okay, but any antipsychotic could cause NMS, neuroleptic malignant syndrome. Okay, now the key takeaway here, and we'll cover the antipsychotics later on, but the key takeaway here is that it causes severe rigidity, severe rigid muscles, and fever. Okay, so serotonin syndrome is hyperreflexia. So when you see, when you do the deep tendon reflexes, they're going to have +4, right? And they're going to have clonus. For NMS, you're going to have lead pipe rigidity is what they call it. Muscle rigidity is just so tensed up, and they will have a fever associated with it, okay? And my favorite thing is mnemonic malignant fever. So neuroleptic malignant syndrome will have malignant fever. The M in malignant is for myoglobinuria, right? Because of that muscle rigidity can lead to myoglobinuria due to the muscle breakdown. And then fever stands for F, fever. E is encephalopathy. V is unstable vitals. E is elevated enzymes or elevated CK, right? Because of the muscle rigidity. And R is the muscle rigidity, okay? So everything essentially is surrounding the muscle rigidity. You're going to have high CK, you have myoglobinuria, and then also you're going to be seeing fever, okay? Now, how do you treat it? You treat it with dantrolene. Okay, dantrolene is very, very helpful with treating neuroleptic malignant syndrome, all right? Now, you could give them dopaminergics because NMS is thought to be due to dysregulation of dopamine, and so that's why antipsychotics can cause it. Just keep that in the back of your mind. That's why they think NMS occurs is because of dysregulation of dopamine. So once again, keep in mind, it's fever and muscle rigidity for NMS. Serotonin syndrome is hyperreflexia and clonus, okay? And remember, look at the medications the patient's taking. That's going to be your key thing. Okay, so now we could go back and kind of run through the other lower yield ones, but still high yield, but lower yield psychiatric emergencies. Hypertensive crisis. So a patient that comes and presents to you and they say that they've been eating a lot of aged cheeses and wines and foods that are rich in tyramine is what they call it. Okay, so those are gonna be your aged cheeses, your wines, nice chocolates, okay? So those foods are rich in this thing known as tyramine. And what happens is, if a patient's taking an MAO inhibitor while eating those things, those foods rich in tyramine, it can lead to hypertensive crisis because MAO inhibitors lead to an insufficient washing out from the kidneys because they last kind of longer in the system. Okay, so for example, what does this mean? So let's say a patient takes a MAO inhibitor, and they stop it. Okay, and a couple days later, they stopped the MAO inhibitor. They're no longer on it. They stopped it like 3 days ago, and they start eating these cheeses and these wines, and they come to you with severe hypertension. Well, remember, the reason behind it is because MAO inhibitors take a little bit. There's a washout period for them to be fully cleared. Okay, so when switching over to antidepressants, like from MAO inhibitors to another antidepressant, you have to have a washout period, okay, because it increases the risk for potential serotonin syndrome, or here, hypertensive crisis if they eat tyramine-rich foods. Okay, very, very important to keep that in the back of your mind. You can give them phentolamine as treatment. All right. Next is delirium tremens. Delirium tremens is kind of the last manifestation of alcohol withdrawal. So if a patient comes to you and they love to hide this, and I'm going to talk about alcohol withdrawal like kind of more in depth when we get to that page next, but essentially what they like to do in question stems is they'll like to hide the alcoholism. So they won't tell you the patient's an alcoholic, but what they will tell you is that the patient has been in the hospital. He had like some type of trauma and it landed him in the hospital. And now randomly on his 4th day of hospitalization, he starts to get these random symptoms. He starts to, experience altered mental status, and he's starting to hallucinate, and he's freaking out, and he's starting to have seizures and tremors. Okay. They're hinting at some type of alcohol withdrawal. Okay, and everything I just described to you is delirium tremens manifestation. So it's alcohol withdrawal that usually occurs 2 to 4 days after their last drink. And it's seen in the hospital setting, right? When you're inpatient, you can't drink, right? When you're actually at the hospital, you're not able to have a drink. So it forces them to kind of get cleaned, and they start to withdraw from alcohol, which is very, very scary. So they get altered mental status, hallucinations, they get anxiety, seizures, tremors, okay, a bunch of issues, insomnia. And the way that you could treat them is long-acting benzodiazepines. But delirium tremens is the scariest part of alcohol withdrawal. We really don't want our patients to go into delirium tremens. Okay, so you're going to give them long-acting benzos to help out here. For the next ones, acute dystonia. This is just going to be caused by typical antipsychotics. Very, very common thing that you're going to be seeing. It's scary, but essentially the patient's going to present with like their head is stuck turned one way. Okay, so that could be like a form of acute dystonia that they're trying to hide in the question stem. So their head's like stuck turned over to the left, or they have like severe like muscle spasms, sudden onset muscle spasms and stiffness. Okay, now once again, not too high yield, but you're going to definitely see it with typical antipsychotics. Okay. Lithium toxicity is just when you give a patient increased amounts of lithium, usually for bipolar disorder, right? You have to remember that it's going to be decreased. Its renal elimination will be decreased by like NSAIDs or ACE inhibitors or thiazide diuretics. Okay, so ACE inhibitors, thiazide diuretics, and NSAIDs, when taking lithium toxicity or when taking lithium, can lead to lithium toxicity. So be careful. If you see someone that's taking NSAIDs and they're also bipolar, you might have to assume that they're taking lithium, or they will tell you that they're taking lithium. And now they're experiencing signs and symptoms of lithium toxicity, which would be like nausea, vomiting, slurred speech, seizures, right? Nephrogenic diabetes insipidus. They love that lithium toxicity can cause nephrogenic diabetes insipidus. Think about the other medications that they're potentially taking, because NSAIDs, ACE inhibitors, and thiazide diuretics can lead to a decrease in renal clearance of lithium, which causes an overall increased risk of lithium toxicity, okay? And it could cause nephrogenic diabetes insipidus. All you got to do is discontinue lithium, okay? And you have to hydrate them excessively. Lastly is TCA toxicity. TCA is just obviously a form of medication, so the cause is TCA overdose. What you're going to be seeing is respiratory depression, but the key things here are prolonged QT. So TCAs prolong your QT, and that could lead to potential torsades de pointes and something that's very scary. Now, what they want you to know is convulsions, coma, and cardiotoxicity. So TCA toxicity can lead to your risk of convulsions and coma, but you also have an increased risk of cardiotoxicity, which is arrhythmias due to sodium channel inhibition. Okay, and we're going to talk about the MOA, mechanism of action of TCAs later on in the pharmacology video, but remember those three things: convulsions, coma, and cardiotoxicity due to sodium channel inhibition. Okay, so that's pretty much our psychiatric emergencies. Focus on serotonin syndrome and neuroleptic malignant syndrome. Those are the two key things that they like to ask about. All right, and that's all.